Welcome to this explainer. Today we're stepping straight into the trauma bay for a rapid-fire review of some absolutely critical clinical scenarios. We're stripping away all the fluff and focusing purely on those split-second life-or-death surgical decisions you've got to master. So let's build up those clinical reflexes. Okay, let's dive right into this. In trauma surgery, you know the golden hour is literally everything. Every single minute counts, and hesitation, well, it can be fatal. Through this continuous drill, we're going to put your knowledge to the test, moving sequentially from the airway straight down to the abdomen, exactly like a real primary survey. Section 1. Urgent neck and chest trauma. Picture this. A 28-year-old guy crashes through the doors with a penetrating stab wound right at the base of his neck. What is the single most dreadful sign that tells you, without a doubt, this patient requires immediate surgery? Is it subcutaneous emphysema, hoarseness, an expanding hematoma, dysphonia, or dysphagia? Well, it's an expanding hematoma. Why? Because an expanding hematoma in the neck is an absolute indication for surgical exploration. It rapidly compresses the airway and major vessels, leading to imminent asphyxia. You don't wait, you don't just observe, you operate. To manage these injuries effectively, you have to lock in the anatomy. Zone I runs from the clavicle up to the cricoid cartilage, which is right where our patient was stabbed. Zone 2 goes from the cricoid to the angle of the mandible, and Zone 3 extends from the mandible all the way up to the skull base. Moving down to the chest now. A patient arrives with blunt chest trauma and a hemothorax. We place a chest tube. What specific output volume from that tube is the alarm bell that tells us we need to proceed to an urgent thoracotomy? And this brilliantly illustrates the difference between an immediate massive fluid dump and a persistent ongoing bleed. If you get more than 1,500 milliliters of initial drainage the second you place that tube, you are going to the OR immediately. Alternatively, ongoing drainage of more than 200 milliliters per hour for 3 to 4 hours confirms a major systemic artery injury, and that also absolutely requires operative control. Let's push into even more extreme territory. Which patient scenario demands an emergency room thoracotomy? We aren't talking about casually wheeling them up to the OR here. We are talking about cracking the chest right there in the trauma bay. The answer is a penetrating stab wound to the left parasternal area, combined with less than 15 minutes of CPR. The golden rule here is that a penetrating cardiac injury with a short CPR duration is still salvageable. Your immediate goals with a rapid left anterior lateral thoracotomy are the relief of cardiac tamponade, controlling the hemorrhage, and cross-clamping the aorta. Section 2. Damage control, liver injuries. What is the absolute best initial step for hemostasis in a severe, grade 4 liver injury? You've opened the abdomen and found diffuse venous and parenchymal bleeding. Do you just start suturing? Do you try to ligate vessels? So, the crucial point is this comes down to one primary damage control principle. Step 1 is always packing and compression. You have to control that diffuse bleeding first. Step 2, if bleeding continues despite your packing, is the Pringle maneuver to clamp the inflow. Step 3 is definitive repair, but that happens much later. You absolutely do not rush to fix everything at once while the patient is bleeding out on the table. Let's test that restraint with a quick comparison. How do you manage an unstable patient with a relatively low-grade, bleeding grade 2 liver injury versus a totally stable patient with a 3-centimeter non-bleeding liver laceration? You know, surgeons love to operate, but you've got to remember this golden rule. Never do a resection in unstable trauma. Packing saves lives. For the unstable patient, the correct management is packing and closure. Conversely, for the stable patient with no active bleeding, avoid unnecessary suturing entirely. Surgery is reserved strictly for persistent bleeding. But what happens when our life-saving techniques actually go wrong? Let's say you've packed the liver to save their life. What is the absolute worst complication you've just introduced by doing that? Liver necrosis. Overpacking the liver causes severe pressure necrosis, and it heavily contributes to abdominal compartment syndrome. This is exactly why the exam pearl mandates that packs must be strictly removed within 24 to 48 hours. You pack to stop the bleed, sure, but you must plan to go back in to prevent fatal tissue death. Section 3. Splenic blunt trauma management protocols. Let's start this off with a classic mechanism of injury. A patient falls from a significant height presenting with shock, or maybe they suffer fractures specifically to the left 9th through 11th lower ribs. What is the most likely injured organ? It's the spleen. The spleen is actually the most commonly injured solid organ in blunt abdominal trauma. Contrast that with penetrating trauma, which most commonly hits the liver. And hey, always watch out for cure sign. That's referred pain to the left shoulder due to diaphragmatic irritation from all that splenic bleeding. Okay, so how do we proceed with diagnostics? A patient has a blunt left lower chest injury. They're at real risk for splenic injury, but they are completely hemodynamically stable right now. What is the immediate next step? Now, what's really interesting here is how stability entirely dictates our diagnostic pathway. For a stable trauma patient, a CT of the abdomen and pelvis with contrast is the absolute gold standard. It beautifully detects solid organ and vascular injuries. If they were unstable, we would skip the CT completely and go straight for a bedside ultrasound, like a FAST exam, or DPL to check for blood. But stable? Stable means we scan. Which leads us right to our final comparison. You've done the CT scan. How does your management differ between finding a stable parasplenic hematoma versus a grade 3 splenic injury that actually shows a contrast blush on the CT? A CT blush means there is an active arterial bleed. Even if the patient is currently stable, that blush requires immediate angioembolization to preserve the spleen and stop the hemorrhage. On the flip side, if the CT just shows a stable hematoma with no blush whatsoever, the management is purely conservative. Strict bed rest, and serial hemoglobin monitoring. We've covered everything from immediate neck exploration all the way to the nuanced non-operative management of the spleen, which leaves us with a pretty compelling final thought. As trauma imaging gets sharper and our endovascular techniques keep improving, how far will non-operative management actually go in replacing the scalpel entirely? Keep that in mind as you review these guidelines. Thanks for joining this explainer, and stay sharp out there.